Well, welcome all. I think there may be a few more folks joining us, but in the interest of time, I'm going to go ahead and get started. This afternoon, we're going to be talking about bowel management after spinal cord injury, and this will be a follow-up to our previous talks on autonomic dysreflexia, spasticity, and last week's neurogenic bladder management. So what I'm hoping to do is we'll talk through the neuroanatomy, including the intrinsic and extrinsic nervous systems, and talk about how they interact. We'll talk through bowel anatomy and physiology, colonic reflexes that, at least for upper motor neuron bowels, we can take advantage of, and then talk through defecation itself. Probably none of us remember going through potty training, and yet we all did it, and it would be really difficult for any of us to accept that we no longer had control of our bowels or bladder. And so as we go through the presentation, just keep in mind how you would feel under conditions where you could no longer control voluntarily bowel or bladder function. So gastrointestinal function obviously is to provide fluid and nutrients to the rest of the body. We, on average, take in about 800 grams of food and somewhere around 1.5–2 liters of water. We secrete 7 liters of fluids into the GI tract through salivary glands, stomach, gallbladder, pancreas, and then the intestines, and then reabsorb about 8.5 liters. So that ultimately we excrete, on average, about 150 grams of fecal material per day. I'm going to spend most of my time kind of talking through the bowel innervation and how that is disrupted after a spinal cord injury. As we go through the model, you'll notice that I've tried to, as much as possible, keep the sympathetic nervous system labeled in red, the parasympathetic nervous system in blue, and the somatic nervous system, to the extent possible, in green. But despite that, we have to remember that there is an intrinsic neuroanatomy to the bowel, and this functions in and of itself, although obviously is modified by the extrinsic nervous system. So I think the key things to keep in mind through different areas of the gastrointestinal tract, you have pacemaker cells, and those pacemaker cells, just like pacemaker cells in the heart, result in contractility of the surrounding muscular elements. And so we have within the intrinsic innervation of the bowel, the submucosal plexus, also known as Meissner's plexus, and the myenteric plexus, also known as Auerbach's plexus, and those contribute to depolarization of the longitudinal muscles within the bowel as well as the circular muscles. And subsequently, we end up with a churning and a propagation of food and subsequently fecal material through the different areas of the GI tract. And again, it maybe doesn't seem to make sense, but different areas of the GI tract will contract at different rates. That is, their pacemaker cells fire at different rates. So in the stomach actually contracts 3 to 5 times a minute, whereas in the small bowel, we see almost twice as much activity as food makes its way through the small bowel, the duodenum, and then as it moves on into the colon, there's even more irregular contractions, and those will respond as well, recognizing that you have intrinsic afferent signals as you have muscular contraction that is also causing afferent signals to go back and then essentially re-innervate, if you will, the bowel as we're working our way through the system. So the Extrinsic innervation includes the somatic innervation, and again, that's in green on this slide, is represented by the pudendal nerve that activates the external anal sphincter and the pelvic floor musculature. We'll talk through this in a little bit, but this provides us a large degree of control, voluntary control over when and where we end up having a defecation event. So again, that comes from sacral roots S2, 3, and 4, and this is part of the somatic nervous system we have voluntary control over. The sympathetic nervous system arises from the thoracolumbar regions of the cords, and we have 22 pairs of paravertebral ganglion innervating the gut through the superior and inferior mesenteric ganglion, T9 through T12, and then lower the hypogastric nerve, T12 through L3. So the sympathetic nervous system modulates the intrinsic nervous system of the gut to reduce GI motility and secretions and provide tonic tone, if you will, to the internal anal sphincter. And then finally, the parasympathetic nervous system arises from craniosacral components. We recognize the cranial portion to the gut primarily is mediated through the vagus nerve and supplies the part of the gut from the mouth to the mid-transverse colon. The sacral parasympathetic nervous system then takes over and through elements of S2, S3, and S4 along the pelvic nerve, basically provide innervation to the mid-transverse colon all the way down to the rectum. And the parasympathetic activity is going to increase gut motility. It will relax the internal anal sphincter and is responsible for stimulating secretions and relaxing sphincters as we work our way through. So as we put all of these pieces together, we recognize that there are some influences to the GI tract that will propagate the expulsion of food on through the GI tract and ultimately down towards the rectum, where again, those with voluntary control are able to maintain continence through voluntary activation of the external anal sphincter, puborectalis, and the pelvic floor musculature. Recognizing also that as the fecal material comes down into the rectal vault, the afferent impulses that come from stretching the rectal vault will ultimately play back and cause relaxation of the internal anal sphincter and makes it more likely that we would have defecation. But again, we hold back on that through activation of the external anal sphincter, the levator ani, and ultimately the puborectalis. And I want to make sure that we recognize that we can coordinate when we're neurologically intact these events and hold, if you will, for a socially appropriate time to defecate. Just as a reminder, however, I wanted to kind of talk through the relationship between the puborectalis and the sphincters, recognizing that contraction of the puborectalis also helps to maintain continence, and it's relaxation of that and subsequently relaxation of the external anal sphincter that allows for typically the normal defecation. As with the bladder, however, the denervation that occurs with the spinal cord injury results in a rectosphincter dyssynergia in this case, so that rather than complete relaxation as fecal material starts to pass over that levator ani sling, if you will, it actually causes reflex contraction and subsequently reflex contraction of the anal sphincter as well. So I want to talk through the colonic reflexes. For an upper motor neuron bowel, we're going to be able to take advantage of all of these. And so first is the colocolonic reflexes. So as you stretch the distal portions of the GI tract, particularly in the colon, that propagates a colonic reflex that causes contraction of the longitudinal and circular smooth muscles as mediated through the myenteric plexus. The gastrocolic reflex is essentially that. As we stretch the stomach, it also mediates a reflex contraction of the colon. Now that doesn't occur immediately, and actually that reflex takes about 30 minutes for it to fully propagate to the distal colon. And so it's not unusual for most folks to have a gastrocolic reflex, and subsequently 30 minutes after a meal, we see a contraction of the colon in response to the stretch of the stomach that occurred about 30 minutes prior to that. We have the rectocolic reflex. So as you get down into the very distal aspects of the colon, into the rectum, as you expand the rectum, it also causes contraction of the distal colon. And so via the pelvic nerve, we end up having additional contraction. The anal rectal reflex is where we take advantage of relaxation of the internal anal sphincter to relax the sphincter. And then the only thing maintaining continence for us at that point is the puborectalis and pelvic floor musculature, as well as the external anal sphincter. If you don't have voluntary control of those, however, it's more likely that you will have stooling at an inappropriate time. Now, the bulbocavernosus reflex isn't actually part of the colonic reflexes, but it is an important clinical reflex that we can use to determine the integrity of the final common pathway, that is the lower motor neurons. So if the bulbar cavernosus reflex is intact, then when we tug on the glans penis with our finger in the sphincter, basically we would feel contraction of the sphincter around our finger in response to tugging on either the glans penis, the clitoris, or the pubic hair will give us a similar type of thing. What that tells us is that the final common pathway, the afferent loop from the glans penis in this case to the spinal cord and ultimately back down to the external sphincter is intact. And so this would tell us that we have, in fact, an upper motor neuron injury, and we're going to be managing that differently than we would lower motor neuron injury. So with a spinal cord injury, what are the components that maintain ongoing control? So we still have digestion and absorption after a spinal cord injury, and in fact that is intact. Colonic transport, however, is markedly slowed after a spinal cord injury. Our primary muscles maintaining continence, the internal anal sphincter, is influenced by the sympathetic hypogastric nerve and the parasympathetic pelvic nerve. Whereas the voluntary control of external anal sphincter, puborectalis, and levator ani are lost, and the person no longer is able to maintain continence through voluntary activation of those particular muscles. It's also important that we talk through a little bit of autonomic dysreflexia, and again, we've heard about this a few times. Anthony Bowlby reported it back in 1890 as a massive sympathetic outflow in response to a noxious stimuli below the level of spinal cord in complete spinal cord injury lesions above T6. That's been modified a little bit over the last 150 years or so, in that we realize that incomplete spinal cord injuries can also result in autonomic dysreflexia and its complications, namely stroke, seizures, organ failure, and in some cases death. So we know that from our discussion last week, the bladder is the primary cause of autonomic dysreflexia. The number 2 cause is, in fact, number 2, that is bowel. And so a distended bowel, an ileus, constipation, diarrhea, all of these can contribute to autonomic dysreflexia. That is a noxious stimuli below the level of the injury. Acute abdomen, and in some cases an ugly one, can also cause autonomic dysreflexia. So appendicitis, cholelithiasis, ischemic bowel, all of those would be sensed, would be felt as pain for an individual who was neurologically intact, but for a spinal cord injury, particularly injuries above T6, in fact, all you get is this massive sympathetic outflow causing autonomic dysreflexia. You also see it in response to a hernia, to trauma, and in fact, cancer. All of those can contribute. So a noxious stimuli of the GI tract could, in fact, be hemorrhoids, for example, which would be very painful if the individual still had sensation, but they don't. And so typically what happens is that noxious stimuli sends afferent signals up the cord that are blocked at the level of the spinal cord injury, and you get this reflex sympathetic outflow resulting in splanchnic vasoconstriction and a hypertensive crisis. Increased pressure is sensed by baroreceptors that send information to the medulla, which ultimately sends information back to the heart to slow it down and to try to dissipate the pressure. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, you see vasodilation, sweating, and a pounding headache we attribute to autonomic dysreflexia. So, with all of those things in mind, what are the goals of our bowel management program? We want to provide a predictable and thorough evacuation of the lower GI tract. We want to prevent constipation and diarrhea, and we want to prevent autonomic dysreflexia. For our persons with spinal cord injury, what they're most concerned about is being able to maintain bowel continence. And in doing so, we can provide them an improved quality of life. Their satisfaction is going to result in better physical interaction with the environment around them, more likely that they will participate in jobs and participate in social events. So again, I brought this up last time, but it's worth repeating. When surveyed, folks with spinal cord injury reported out that out of all of these different functions that I have listed there, folks with tetraplegia most wanted to have arm and hand function, and then they would like to, if at all possible, have sexual function, trunk stability, and then control of bowel and bladder. Those with paraplegia listed as first and foremost sexual function, and we'll talk about that next week. But their number two concern, if they could change something, it would be to have control of their bowel and bladder. And so when you take a look at all individuals with spinal cord injury, the most important things to them aren't walking, which might be surprising to some of you, but are actually having the ability to participate fully in sexual activities and to have control of bowel and bladder function. So over the years, there has been much more research that has gone in bladder management as opposed to bowel management. And recently, we've put together papers talking about what outcome metrics should we pay attention to in preclinical research, that is animal models. And that includes the things I have listed here: immunochemistry, fecal analysis, whole gut transit studies, motility studies of the distal colon, and colonic smooth muscle tension recordings. With regard to clinical research, there are a number of other things that are listed: bowel diaries, the physical exam, imaging studies, including defecography, endoscopy and colonoscopies, gastric emptying studies, including the use of wireless motility capsules, anal rectal manometry, so what kind of pressures are we seeing, particularly in the distal aspects of the colon, and then EMG and nerve conduction studies of those lower elements. The other aspect of bowel management research that was really brought forward is subjective self-reports of quality of life scales. So the Qualavine 30, the short form Qualavine, and the neurogenic bowel dysfunction score, all of these are considered priority areas and things that we should be taking advantage of when we embark upon bowel management research. So these are quick set orders that should be available to all of our residents and students in the Cerner quick set orders. Typically we're going to ask for the bowel program upright on a padded commode if at all possible. Otherwise, left side lying is superior to right side lying on the bed. And then the first and probably the most effective intervention that we would use would be the bisacodyl in polyethylene glycol, that is PEG, suppositories per rectum, followed by digital stimulation for 30 seconds every 10 minutes for up to 1 hour, and then documenting the results, including the amount and the consistency of the fecal material. Ideally, and again, these all should be listed in the orders that come through to the nurses. Ideally, this is going to be 30 minutes after a meal. For individuals with spinal cord injury above T6, also document baseline heart rate and blood pressure after each digital stimulation, recognizing that we're concerned about the possibility of autonomic dysreflexia. And if in fact our bowel care program is causing autonomic dysreflexia, then we need to consider modifying it. And I'll talk through that in just a moment. While they are doing their bowel care program, encourage abdominal massage, where they actually massage the different aspects of the transverse and distal colon. Doing weight shifts on their padded commode after each digital stimulation will also help to promote propulsion of fecal material through the distal colon. And then initially we'll start off with once daily bowel care. But if we get to the point where once daily bowel care results in only mucus production every other day, then we can decrease the frequency of our bowel program to every other day. Mucus production without fecal material tells us that we've got an empty rectal vault and that we can go typically an extra day as we go through there. Now, if in the process of doing our bowel care program, we do in fact cause autonomic dysreflexia, then we want to consider switching to other alternatives. So enemies, mini enema, and again, I'll talk through these a little bit further in the talk, would be my next go-to, followed by enemies plus if I'm still seeing autonomic dysreflexia with the enemies mini enema. Enemies plus has a nuprocanol jelly associated with it. And would be less likely to cause autonomic dysreflexia. But if I still see it, then I would consider switching over to a glycerin suppository, which doesn't have the chemical noxious components that would be seen in bisacodyl suppositories. And then ultimately the bisacodyl and vegetable oil suppository, typically I wouldn't go back to this. This one takes about 3 hours to melt and is really a suboptimal way to manage bowel care. So rather than going backwards and doing that, I would see what kind of a response I could get just with digital stimulation every 10 minutes, even without a suppository. And again, this is in the face of ongoing autonomic dysreflexia in response to the bowel care program. For lower motor neuron bowel management, there's also a quick set order for the physicians to put in. This is going to skip the reflex activities that we would see with an upper motor neuron bowel and basically provide daily digital disimpaction, ideally 30 minutes after a meal, upright on a padded commode to allow gravity to facilitate, and then encouraging abdominal massage from the patient themselves and periodic weight shifts while they're on the padded commodes. Again, documenting the results, including the stool amount and consistency, is going to be very important. Our occupational therapists are going to help us to determine what is the most appropriate bowel care equipment, recognizing that most folks with paraplegia are going to need minimally a padded commode chair, and this is going to also allow them to stay stable During this time, in some cases, we would include a lap belt to help hold them in place. They typically, persons with paraplegia will be able to have sufficient hand function, but maybe not enough balance. And so they still might need a suppository inserter to be able to insert and do the digital stimulation by themselves. For folks with higher levels of injury, you may have to use a more advanced type of a bowel a bowel chair. So this is a RAS, for example, which allows for tilt and again, keeping the individual who doesn't have truncal control safe by using typically a Velcro belt or a seat belt across them during the bowel care program is going to be important. So I want to talk through briefly the differences between upper motor neuron and lower motor neuron bowels with regard to the bowel care program. In a nutshell, the upper motor neuron bowel is going to allow us to utilize reflexes, both chemical as well as mechanical reflex, to stimulate evacuation. Whereas with a lower motor neuron bowel, a flaccid sphincter, we're going to have to resort to simply passive evacuation. So an upper motor neuron bowel, typically we're going to have reflexes, but we won't have voluntary defecation per se. We're going to have to take advantage of those reflexes. Since those reflexes remain intact, then we can move through these components. So again, we're going to have the individual upright on a padded commode, have a high fiber diet, somewhere between 15 grams and 30 grams of fiber a day, with appropriate fluids so that you don't become constipated. We're looking for a fecal material that is soft and formed, and we will achieve that through the use of appropriate fiber and bulk forming agents, stool softeners as we go through there. Now we're going to be using in an upper motor neuron bowel program, we'll be using both chemical as well as mechanical reflex stimulants. So the contact irritants included a bisacodyl polyethylene glycol base suppository and digital stimulation, recognizing that depending if the person is having problems with autonomic dysreflexia, we're going to go through this in a sequential order, basically looking for the best means of getting a good evacuation without causing significant autonomic dysreflexia. Ideally, again, 30 to 60 minutes after a meal, and that's going to vary upon the individual, but we want to optimize the gastrocolic reflex. We'll use Valsalva for those individuals who can bear down and have abdominal musculature to do so, but also using abdominal massage and weight shifts as necessary. Again, we'll start off with daily bowel care, recognizing that oftentimes the person is going to be in spinal shock. And even though we're implementing an upper motor neuron bowel program in the early phases, the bowel may act like a lower motor neuron bowel because, again, it's in spinal shock. The ideal is to try to minimize the amount of time required to do the bowel program to get a complete evacuation, and to minimize the likelihood of fecal incontinence afterwards. Now, the digital stimulation, again, employs the circular motion of the wrists using the digit in a glove, in a lubricated glove, applying gentle pressure to the bowel wall in a 360-degree direction for 20 to 30 seconds, repeating this every 10 to 15 minutes. It really shouldn't last more than 1 hour. We should be able to get a complete evacuation within 1 hour. Also recognizing that we're going to be adding in abdominal massage and weight shifts. And I want to make a note of this. Before you do your bowel care program, it's ideal to empty the bladder. And the reason for that is a distended bladder is a noxious stimuli below the level of the injury that can in fact cause autonomic dysreflexia, that sympathetic outflow to the bowel is going to slow the bowel down. And so we certainly don't want to be slowing the process, which is why we should do our bladder program prior to the bowel care program on any given day. Now, as we mentioned, the lower motor neuron bowel, the reflex activity that we could take advantage of with an upper motor neuron bowel no longer applies because you've got disruption of that final common pathway, either the afferent and or the efferent loops from the cord, so that we no longer have spinal cord mediated reflexes and can't take advantage of either the chemical or the mechanical reflexes that we used in an upper motor neuron bowel. So now, again, we're going to have the person upright on the commode, if at all possible, to allow gravity to assist us. We're again looking for a high fiber diet with 2 to 3 liters of fluid a day. Now, instead of a soft form stool, we're looking for a firm but not hard stool, recognizing that the person is going to have a flaccid sphincter, and so you want to have it less likelihood that fecal material is going to slip out during transfers, weight shifts, etc. We're going to use stool softeners as necessary to get to the consistency that we need. The reflex that we do have control of still is the gastrocolic reflex. And so again, doing this 30 to 60 minutes after a meal would be ideal, but recognizing now that we're not going to be able to use suppositories and digital stimulation to facilitate reflex contraction of the distal colon. So now everything is going to be basically manually disimpacted, and yet we can still use Valsalva, we can still use abdominal massage and weight shifts to facilitate emptying. This is likely for a lower motor neuron bowel going to have to continue on a daily basis because, again, you have a flaccid sphincter, not a hyperreflexic sphincter as we see in an upper motor neuron bowel. And so a lower motor neuron bowel is more likely to leak because of that flaccid sphincter. So as much as possible, we could make a comparison between our upper motor neuron, lower motor neuron bowels, recognizing that certain aspects, the fiber, using stool softeners as necessary. As much as possible, you want to be able to accommodate the person's lifestyle. And so if they're somebody who's going to get up early and need to go to work, it's probably important that they do their bowel care before they go. Not always, but more likely, in order to have a full day of continence. On the other hand, some folks just can't seem to get up early, and so for them, it may be important to instead do their bowel program at night after meal, and hopefully get that done in a way that is going to continue moving on to an every other day or potentially even an every third day bowel care program. We want to try to keep this less than an hour. I think anything more than an hour a day or even more than an hour every other day, that's still taking too much time. And we should be able to optimize their bowel program to keep it under an hour a day. If we're seeing mucus but without fecal material, typically that tells us that our frequency can be changed so that we can go to every other day, or in some cases even every third day as we go through this. If I've got somebody who's coming to me and they're having problems with their bowel care, either incomplete emptying or incontinence on the days in between, then typically I'm only going to change one feature of their bowel care program at a time. It may be the suppository, it may be the way that we're doing digital stimulation, it may be fiber or stool softeners, but typically I'm not going to know how well they respond for 3 to 5 bowel cycles. So that part of the process is going to require patience. So this is more for the clinicians. Typically, we're going to be monitoring bowel sounds, palpation along the colon, and the rectal exam is going to tell us whether or not we have an upper motor neuron hyperreflexic sphincter or a lower motor neuron flaccid sphincter. And again, the bulbocavernosus reflex tells us whether we have an upper motor neuron bowel, in which case the reflex would be intact, or a lower motor neuron bowel in which the reflex pathways are broken as we go through there. So pharmacological management, we can start talking about just the diet and including high fiber foods, but we may need to as well use fiber bulk agents. Psyllium, so Metamucil and Consul are basically fiber elements that will improve water reabsorption and help hold water in the stool. Methylcellulose or Citracel is another type of a fiber product. Calcium polycarbophyll with PEG, or also known as FiberCon. Tasteless, colorless, odorless is sometimes the fiber of choice. Wheat dextran, so Benefiber, for example, is the choice of some folks, but not all. And remember, in all of these where you're going to be taking additional fiber, you're going to have sufficient water, or you're likely to cause constipation. We're also going to consider stool softeners, which emulsify the fat and reduce the water reabsorption, that is, increase the water content of the stool. So docosate sodium cholase is probably the one that we use most frequently. Some folks respond better to docosate calcium, so Surfac. Recognize that neither of these will enhance bowel transit or peristalsis, and that both still require significant water intake. Now, we're playing that balancing act between not having too much water that would cause problems with our bladder. On the other hand, we don't want to have overly dry or firm stools as we're going through this. Lubrication is necessary to prevent injury to rectal mucosa, so we're going to typically recommend Surgilube or KY jelly as the person is doing their bowel program. Lidocaine jelly, so Anusol, Nuprocanol jelly may be necessary in some cases, particularly as we're seeing autonomic dysreflexia in response to our bowel care program. A number of different laxatives can be used, but I would always caution people to use these sparingly, whether we're using salts such as magnesium citrate or milk of magnesia. Sugars, so lactulose, for example, is a synthetic disaccharide that can be used. Glucitol is a sugar alcohol. Product name is typically sorbitol. Recognizing that both of these can cause significant electrolyte abnormalities and what we call a lazy bowel, which is actually not a medical diagnosis, but it simply refers to a bowel that doesn't respond to typical reflex maneuvers. Polyethylene glycol 3350, so this is a product that's used most frequently for colon prep prior to doing a colonoscopy. PEG 3350 is also found in Miralax and Go Lightly, which is polyethylene glycol plus several different salts. Again, we don't like to use this routinely for our folks with spinal cord injury because it can lead to electrolyte abnormalities and a lazy bowel. Senna is appropriate early in the rehab course and maybe even within the first year or so, but typically I try to get folks to wean them off of Senna within the first 12 months or so. Senna stimulates the Auerbach's plexus and again can be very helpful in establishing the bowel program, but over time it can lead to melanosis coli and ultimately paralyze the intrinsic nervous system of the gut, so that you end up with essentially a lower motor neuron valve of the intrinsic nervous system. So we want to prevent that as much as possible. Motility agents. This is difficult. This is how do we get things to move more quickly through the GI tract? And unfortunately, we don't have great options, even though I've got a number of things listed on this slide. Bethanechol is not a great gut motility agent, and its use is certainly off-label. Anticholinesterase inhibitors, such as neostigmine, can cause significant problems with bronchospasms and cardiac arrhythmias. So it has been trialed along with glycopyrrolate, which is a selective anticholinergic agent. When administered either IV or through ontophoresis, this promotes bowel evacuation without significant cardiopulmonary side effects, but it's just not a practical way to manage bowels. At least at this point, there's ongoing studies looking at that. Prokinetic agents, so tegeserod, Zelnorm has been withdrawn and is only appropriate when you have IND protocols, investigative new drug protocols, which we typically aren't seeing in our spinal cord injury trials. Regland metoclopramide is a cholinergic agonist, as well as a dopaminergic antagonist, and it increases gastric but not colonic motility. So it helps us in the beginning of the GI tract, but not so much at the end where we really need it. And major side effect of this agent is the dystonias associated with sedation and or again, these extrapyramidal side effects. It's contraindicated in folks that are using antidepressants or MAO inhibitors. So again, not a great agent. It's something that I use if I have to. Cisapride, which stimulates myenteric plexus acetylcholine release, has also been withdrawn from the market due to side effects, particularly increasing the QT interval and causing torsades de pointes. The option, if we have somebody who we feel like is having significant constipation and the slowness moving through is because of opioids, we can consider a mu opioid receptor antagonist, such as methylnaltrexone or naloxegol. Either of those may be helpful, but again, really only should be used in cases where we're pretty convinced that the slow transit time and constipation is due to the use of opioids. And then erythromycin can be used to stimulate motilin receptors in the upper GI tract and is something that I will use occasionally. Again, I don't have many other options as we talk about motility agents, and this is certainly an area that needs more study and investigation. We've got our contact irritants, and I talked a little bit about the bisacodyl suppositories. These are essentially supposed to irritate the bowel wall and stimulate peristalsis. As we use these, again, you've got a couple of different opportunities. The Docolox in the vegetable oil base is not a good call for us. I'm sorry, I'm getting some feedback and I'm not quite sure why. The Magic Bullet suppository, that is the bisacodyl and a polyethylene glycol base, is really my suppository of choice. And the only concern there being if it's stimulating significant autonomic dysreflexia. But the Magic Bullet suppository, this bisacodyl and a polyethylene glycol base, is going to give us literally the most bang for the buck. It melts fairly quickly, and so you get a full noxious stimuli to the bowel wall that is going to cause the colonic contraction. The concern being those folks who are having problems with autonomic dysreflexia. in which case we might have to slip to the enemies or glycerin suppositories. Enemies contains docosate sodium, polyethylene glycol, and glycerin, and the enemies plus also includes benzocaine, 20 milligrams, so it makes it less likely that a person is going to have autonomic dysreflexia. Again, we need to be keeping track of heart rates and blood pressures as we're doing our bowel care and going through this process. The bowel care program is one of those issues in acute spinal cord injury and chronic, if we have to admit folks with a chronic spinal cord injury, that we really do need to pay close attention to and make sure that we are giving appropriate nursing support throughout the bowel care program. If you've got multiple individuals on the unit at the same time, you need to make sure that you have sufficient staffing to be able to perform a full evacuation, because a person that isn't fully evacuated is very likely to have bowel accidents during their rehabilitation, during their therapy sessions and whatnot. So this, along with bladder management, one of the most important features of the nursing management of spinal cord injury. I don't like to use other types of enemas. The soap suds enemas, they work, but again, they contribute to a lazy bowel. Smog is a combination of mineral oil, glycerin, and saline, again, provided to folks who were just not getting adequate evacuation otherwise. There's a great website that's still up called conceptsandconfidence.com, and it promotes some of Stephen Steen's early work back in the 90s and around the turn of the century. Dr. Steen's is an individual with thoracic paraplegia himself, and so was particularly vested in bowel care programs and trying to promote research in this area. Other management options include, so the item up on the top here is a system that is basically transanal irrigation, so providing retrograde enema. It's got a rectal catheter. Let's see if I can get my arrow working here. A rectal catheter and a balloon, basically. So you insert this and then you inflate the balloon. You manually pump fluid into the lower portion of the bowel, and then once you've filled the bowel with the appropriate amount of fluid, then you let the balloon down and remove the catheter. And this is supposed to help with emptying the distal portion of the bowel. You can consider surgical procedures to improve bowel time. That decreases the need for medications and hopefully reduces morbidity. In some cases, we do this on purpose because we've got, for example, wounds, so significant pressure injuries around the perianal region. And in order to heal those and or including surgical healing of these pressure injuries, we need to make sure that we're not stooling in the area. And so they sometimes will do a diverting colostomy just long enough to get that healed, and then they will reverse it. Colostomy is a whole nother lecture in and of itself. There are psychosocial implications as well as the equipment, but we have ostomy care nurses that can help us with this, recognizing that we may be doing a fecal diversion and or ileostomy, depending upon the situations. The Malone antigrade continence enema is another option where they actually basically use the appendix and develop a catheterizable stoma into this portion of the bowel, and essentially you do an antigrade that is forward propulsion of an enema. This was primarily used with children who had spina bifida, myelomeningocele, and then lower motor neuron bowels, but in some places is becoming a method of choice. I don't know that we have this available right now at University of Miami in Jackson, but I'm reaching out to the surgeons. I think it's actually the urologists that have done these in the past, but I'm not sure if we have current surgeons who are promoting these systems. We also have the bowel and bladder, used to be called the Vocare bowel and bladder. This is a functional electrical stimulation system where we actually stimulate contraction of the colon. Again, you can set this up so that it selectively evacuates the bladder and or the bowel, and the newer systems also allow for, it stimulates an erection. And so unfortunately these aren't available commercially in the United States. They have the Brinley stimulator over in Europe, and quite a few folks are using that, at least as I talked to my colleagues over there. But there weren't enough people using these to make it a commercially viable product here in the United States. We need to speak briefly about complications associated with neurogenic bowel. So bloating and abdominal distension occur in more than 50% of our folks. Also, more than 50% of folks will develop hemorrhoids. Unless the hemorrhoids are significantly causing autonomic dysreflexia, typically we're not going to manage those. If there is autonomic dysreflexia associated with the hemorrhoids, then we will go to surgical banding, eliminating the hemorrhoids, knowing that they will probably return, but hopefully, if they return, they wouldn't cause the noxious stimuli that was contributing to the autonomic dysreflexia. Constipation is one of the major problems with our folks. Again, trying to get the consistency of the stool right is very, very important. And so modifying fiber, modifying the stool softeners, and then taking a look at the medications the person is using, all will contribute to this. We recognize that there is something called obstructive constipation or obstipation. I don't know if that term is still used, but back in the day, that's what we called it. This is where you have such constipation that essentially the person ends up having to get admitted with intractable autonomic dysreflexia, all related to obstipation. And so clinically, we're going to be looking at clinical findings associated with significant constipation, using KUB and or barium enema to determine where exactly the blockage is, providing volume resuscitation, so IV fluids, nasogastric tube to decompress the upper GI tract, considering use of oral agents including mag citrate or PEG 3350, and then trying from below bicicotal PEG suppositories, digital stimulation, and an enema as necessary. And then I typically am going to be getting a GI surgical consultation because this could, like I said, precipitate significant autonomic dysreflexia and death if we don't get it under control sooner rather than later. Diarrhea is also a problem in our folks with spinal cord injury. The #1 cause of diarrhea in spinal cord injury is in fact constipation. So you have a blockage and then you just pour liquid around that, and it's always a little bit shocking to folks for me to hear my take on this. I think that your most likely cause of diarrhea is constipation, and so we're going to go through full bowel care program trying to get that taken care of. Recognize that other things can contribute to diarrhea. Spicy foods and caffeine are also going to be contributors to this. And then we have serious complications, probably the most serious of which is autonomic dysreflexia, but several other things can be contributing to an acute abdomen, and so we have to consider all of those elements as we're working with our folks with spinal cord injury. Finally, we recognize that accidents, bowel accidents and bladder accidents in public can lead to social paralysis. So loss of voluntary control, fear and embarrassment of bowel accidents. For you or I, this would be devastating. And it's no less so for our folks with spinal cord injury who simply don't have voluntary control now over their sphincters. This contributes to significant loss of work time and depression, and again, social isolation. So education, 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 helping folks understand that accidents do happen inadvertently, and as much as possible, we're going to educate you to prevent that as much as possible. If you are having incontinence, then you should come to your spinal cord injury physician, and we should talk through what are the different components, make sure that we assess to make sure that we get this taken care of. So I didn't see any hands coming up as I was going through the presentation, and I also didn't see any questions coming up on chat. That being said, there may be questions now. I'd be happy to stay on for a couple of more minutes and answer those. Make sure if you're going to ask a question that you open your mic. Otherwise, it makes it difficult for me to read lips. Wow, I might have put you all asleep. Again, I will stay on for another couple of minutes. If you want to type in a question through chat, that's fine. And if you just want to leave, I understand that as well. So thank you very much for your time and attention. Again, probably one of the most important areas of spinal cord injury rehabilitation, one that we really do need to make sure that we're paying appropriate attention to. So thank you for your time and attention. I'll stay on for an extra minute or so in case there are additional questions. All right, that being the case, I hope you all have a great day. Next week, we'll be talking about sexuality and fertility after spinal cord injury. Again, thank you very much for your time and attention.